Dr. Burnett and I join you today to review a series of questions that we oftentimes get from patients, either via email or through our patient portal. People will ask some of these questions, and we'd like to take a moment to review some of the more common questions, and we hope that you enjoy the information. I guess,
Jeff,
since it's a surgical question, I'll go after it. A little bit of that. I would say, in generally speaking, if you've got thyroid cancer, do you need surgery right away? The answer to that would be yes. I don't think that I've ever advised a patient, if they know that they've got a thyroid cancer or if they have a cancer of any sort for that matter, to delay surgery and kind of wait things out. There are rare instances where people maybe have small, what we call microcarcinomas that are less than a centimeter, and there are some studies to show that you can watch those for a long time and they'll generally do okay, but that's generally speaking very small thyroid cancers. And honestly, most patients, when they know they've got a thyroid cancer, can't wait to have it out, and we're obliged to do that here. That being said, when we visit a patient here, we have a rather unique system insofar as we have a whole host of individuals that can meet with patients in rapid succession. If Dr. Burnett, for example, sees a patient, they've got a thyroid cancer that he diagnoses in clinic, I'll typically see the patient within a few days, or even the same day. If Dr. Burnett calls me on my cell phone and says, "Hey, I've got somebody here that needs to see a surgeon," we have them visit with a preoperative evaluation clinic. That can be done within even the same day that they see me. And most folks, when I see them in clinic, if they have a biopsy-proven cancer, they can be off to surgery within a week or two. And we really try and streamline things, even for complex patients who have bad disease, multiple lymph nodes in the neck, multiple lymph nodes in the central compartment or in the lateral necks, that type of thing. We're able to get them seen right away, diagnosed right away, and get them to surgery right away, so that they need other interventions, like radioactive iodine, for example, that they can kind of move on to those interventions and be cancer-free. And if they don't need anything else, then they'll been treated expeditiously for their thyroid cancer. So generally speaking, I think most folks, I would advise them to have surgery right away, unless there's a medical reason why they shouldn't, or they have a very, very small thyroid cancer that they have spoken with an experienced endocrinologist about and have made a group decision to watch long term. But most folks, we proceed right away.
I'm going to give a little bit of an addition on this. So I do think there is a role, because it's been part of the ATA guidelines since 2016, for active surveillance when you have these sub-centimeter thyroid nodules that appear to be papillary thyroid cancer or are biopsy proven to be papillary thyroid cancer, because there's building data from research done in Asia and Japan and also in the US that these nodules can many times stay inert, not grow, and not be a medical necessity or something dangerous to your health to have removed and stuff like that. So there is this balance. And we talk to patients when we think they fall under the active surveillance category. So, but I definitely agree that if they don't fall under that active surveillance, or the patient is just very unclear, uncomfortable with wanting to do active surveillance, then surgery can be done. And I would ask Dr. Janis, because doing surgery right away means a lot of things to a lot of people. So how about sharing a time frame, what you mean like that? So because
yeah, no, like I said, we try to get folks in within a couple of weeks, within 2 weeks for surgery here. I think the most I would push somebody out for treatment of a well-differentiated thyroid cancer, and we can talk a little bit about different types of thyroid cancer because they have different timelines, but for a well-differentiated thyroid cancer like papillary thyroid carcinoma, I think waiting up to 6 weeks is probably okay. I wouldn't push somebody out much further than that. Like I said, most folks we get in within 2 weeks max here. unless there's some kind of extenuating circumstances why we wouldn't be able to do that.
And then the one caveat I would give on that is in pregnancy, there's good data to show that if a woman is diagnosed with a differentiated thyroid cancer, can be safely monitored. Yes, we can do surgery. Usually that would be in the second trimester. But if it's found more in the third trimester, very successfully have followed these patients closely and then taken the steps that we need to take after delivery and such. And because there are certain concerns about taking women to surgery if it's going to be of a low risk. But I agree with Dr. Janis that most patients we get handled within 2 to 4 weeks, and usually wouldn't tell people to wait more than 6 to 8 weeks or thereabouts, unless there are special circumstances.
Yeah, so again, it depends a little bit on what you have, right? So generally speaking, when we look at things like well-differentiated thyroid cancer, right? So papillary thyroid carcinoma and follicular thyroid carcinoma, that's a little bit based on size and how aggressive it's behaving. When we look at other sort of more aggressive subtypes of thyroid carcinoma, like medullary thyroid carcinoma or anaplastic thyroid carcinoma, those for every case of medullary cancer, you're going to get a total thyroidectomy without, with limited exception. And if possible, for cases of anaplastic thyroid carcinoma, we would also want to do a total thyroidectomy, in addition to doing some other sort of lymph node dissections for both of those cases. So for medullary and anaplastic, it's a bit different. For well-differentiated thyroid carcinoma, which is what the vast majority of people have, papillary thyroid carcinoma or follicular, a little bit's going to be dependent on size and how aggressive it's behaving, right? And so if you have a thyroid carcinoma that is greater than 4 centimeters, generally speaking, we'll do a total thyroidectomy. If it's less than 4 centimeters, we try to do a hemi, removing only half of the thyroid. This is based on the guidelines that Dr. Burnett actively participates in writing. There are a couple exceptions to doing just a lobectomy when something is less than 4 centimeters. If the cancer is behaving poorly, right? So if it's it's grossly coming outside of the shell of the thyroid, we call that extrathyroidal extension. We'll do a total thyroidectomy in that case. If there are visible lymph nodes in the central compartment, right? So I'm doing the surgery and I'm planning on doing just a lobectomy, but while I'm doing the surgery, I notice that there are several lymph nodes, and we send those off for frozen section pathology, where the pathologist will actually look at the specimen while you're asleep. And the pathologist tells me, yeah, those actually have metastatic thyroid carcinoma in them. Then we would do a total thyroidectomy, right? So metastatic lymph nodes and extrathyroidal extension are exceptions to that rule. And obviously, if something's over 4 centimeters, we'll do a total thyroidectomy as well. There are other things that can sometimes show up on permanent section pathology, which would require us to do a completion thyroid, removing all the thyroid at a later date. Some of that includes a high level of angioinvasion or lymphovascular invasion, or perineural invasion.
You might want to explain what angio and lymphovascular invasion is, because some of our listeners might not quite know that.
So there are some things that can show up in the permanent section pathology that will sometimes have force us to do a completion thyroidectomy, meaning that we'll have to take somebody back to the operating room at a later date and remove the other half of their thyroid gland. These things don't necessarily always show up on frozen section analysis, or it can be difficult to determine, while you're asleep. Those things are lymphovascular invasion, right? So where the cancer is behaving aggressively, and in the thyroid gland itself, there's evidence of it invading the little blood or the little lymph channels inside the thyroid gland. That's one indication for a completion thyroidectomy. Also perineural invasion. So sometimes if we take the thyroid out and it's looking okay, but when we look at it under the microscope later, it looks like it's invading some of the nerves that were around the thyroid gland. Those things can be indications for us to do a completion thyroidectomy. Lastly, one thing that does come up frequently, and I know Dr. Burnett could probably comment on this, and this is an area that's kind of a hot topic or an area for debate is when people have microsatellites or multiple nodules of thyroid cancer in the actual thyroid itself. So when they've got multifocal disease, and typically speaking, if people have a couple of microfoci of papillary disease, so they have like a single 1 centimeter tumor and a couple of 1 or 2 millimeter tumors, we don't tend to do a completion thyroidectomy. But when they've got a high level of multifocality, sometimes we'll consider doing a completion thyroidectomy at a later date. Typically, that's like above 5 microfoci of tumor. But I don't know, Dr. Burnett can maybe comment on indications for total thyroidectomy. But those are the general sort of rules that we use for hemithyroidectomy versus total thyroidectomy in these patients.
I love to comment historically. So I've been in this business for a while, and it used to be that we really did a one size fits all. Most thyroid cancer patients got a total thyroidectomy, and then were followed up with a radioactive iodine treatment. And I think that there's building data that extent of treatment is unnecessary, and we really need to do individualized care, which I think that's what patients are interested in as well. So now we have more and more data where a lot of patients can safely be managed with a hemithyroidectomy. The advantage is they get to keep some of their thyroid and that thyroid function, and where, maybe 75 or 80%, if they have no other underlying thyroid pathology, won't even need thyroid hormone after the surgery. Another 20 or so percent might need some, but they'll only need a supplemental dose because their thyroid that's remaining will still be able to make that. And that makes their thyroid hormone levels smoother when they're not totally dependent on thyroid hormone. And so I think if you come to a major medical center like Mayo Clinic, that's academic in nature, you're going to get this thoughtful approach of saying, okay, what are the advantages of doing a hemithyroidectomy, so removing part of your thyroid, versus doing a total, and then what that would mean for follow-up and such. And we give patients information, explain, answer their questions, and explain all everything means, and then we come together and make a plan that fits that patient's needs best. When patients really, because they have concerns about other nodules in their thyroid, want the whole thyroid out, that can potentially be done. Other patients are like, no, I want to keep some of my thyroid, and you can take out the half that we're concerned about, and I want to maintain that, even if it has a nodule that we're going to need to monitor, which we had tools to be able to do that with. So I think the message is the ATA is really calling American Thyroid Association for de-escalation and not having everyone get a total thyroidectomy, because it's not necessarily benefiting from that for them, and it can have clinical issues. You're exposing both of the nerves that go to your voice box. You're exposing all 4 parathyroid glands to potential injury. And while, again, in a high volume surgeon's hand, such complications should be pretty low, they're never zero. And so when you're doing a hemithyroidectomy, you're only exposing 2 of the 4 parathyroid glands. You only need 2 to maintain normal parathyroid function and keep your calcium levels okay. And then only 1 of the nerves is exposed, so there's less potential for complications. So we really try to individualize care as regards for extent of thyroid surgery.
So first, let's talk a little bit about risks of thyroid surgery. So we're going to talk a lot about thyroid surgery. Let's talk about some of the potential complications. Again, I think that what Dr. Burnett will impart on people, and what I would impart on folks as well, is it's really, really important to go to a center that does a lot of this sort of thing. Okay, and so high volume surgeon is considered to be, if you look at the literature on this, it's considered to be somebody who does over 50 of these cases a year. We do hundreds of these cases every year, and so we are a high volume facility. There's not much that people can present to us that we haven't seen before, and there's a lot of value in that. And the literature would support the fact that in a high volume surgeon's hands, risks of a lot of these complications are really, really, really low. And we'll talk about kind of the risk of these complications in just a moment. But I also think it's important to know, too, that there are now ways that you can identify high volume surgeons or people that work on a lot of these cases versus folks that do them casually. One of these things is a focused practice designation that has been issued by the American Board of Surgery, as well as our American Academy of Otolaryngology head and neck surgery. And this is a designation, which I have, that is based on participation in multidisciplinary care, right? So you're participating in a tumor board with a lot of different specialists. This is something that's important to be able to discuss complex cases and come up with solid treatment plans for folks who may not have a case that's as straightforward. It's based on experience, right? So, folks have to have at least 120 or more thyroid and parathyroid cases over the course of 3 consecutive years, which includes a total of a minimum of 24 complex cases. And again, we far exceed those requirements here at Mayo Clinic, Florida. You have to have a valid medical license. You have to have professional activity, be actively engaged in thyroid and parathyroid research and academic activities, and have to have adhere to the American Board of Surgery and the American Academy of Otolaryngology ethics and professionalism standards. So there's a lot of requirements that kind of go in this, and it's a process to submit all of it. But there are folks that have this designation, which kind of differentiate them as people who do this a lot versus people who do it not as much. That being said, complications do happen, although rare. The main complications that I talk to patients about are recurrent laryngeal nerve injury, which you'll read a lot about, right? Everyone's worried that their voice is going to be different after thyroid surgery, and the recurrent laryngeal nerve and the external branch of the superior laryngeal nerve are 2 nerves that go to the voice box that every thyroid surgeon should be finding when they're removing the thyroid gland. The external branch of the superior laryngeal nerve goes to the cricothyroid muscle, and it helps with vocal cord tension. And honestly, people who speak a lot or who sing, if that nerve is affected, and it's a very small nerve, and actually in some cases difficult to find, will complain of hoarseness, even though their vocal cords look like they're working normally. The recurrent laryngeal nerve is a different, much larger nerve, and it innervates the rest of the muscles of phonation in the voice box, and this should be found during every case. Injury to that nerve, injury to either of these nerves resulting in temporary hoarseness happens in about 2 to 5% of cases, and that's temporary hoarseness. Permanent hoarseness as a result of injury to one of these nerves in experienced hands is less than 1%. It should really, particularly for benign disease or for small nodules that aren't coming outside of the thyroid, it should essentially be a never event in my mind. So we take special care here when we're dissecting out these nerves to make sure that they are intact. We use recurrent laryngeal nerve monitoring during the case, and just have experience looking for the nerve, which I think are all helpful in making sure that we don't injure the nerve during the case. That's one. So hoarseness is one complication. The second thing I talk to patients about is actually the most common complication, which is bleeding. People can get blood collections under the skin after this operation. That's called a hematoma. Hematomas, fortunately, happen in less than 2% of cases. So 1 out of every 50 to 100 cases, unfortunately, someone will get a blood collection underneath the skin that requires a trip back to the operating room for us to drain. Bleeding around the airway can sometimes be exciting. If you bleed enough and it compresses the airway, it can cause the kind of excitement that we don't like. It can cause an airway emergency. And so we take these very seriously, and obviously do everything that we can during the operation to mitigate that risk and make it as minimal of a risk as possible for our patients. The third thing we talk to people about is parathyroid injury. Parathyroids can be accidentally removed during these cases, and they can be devascularized during these cases. And if that happens, actually, if it happens to all 4 of the parathyroid glands, it can be a real conundrum for the surgeon and the endocrinologist, because the parathyroid glands are responsible for regulating calcium in the body by leaching calcium off the bones to maintain calcium homeostasis in your bloodstream. And if you have injury to all 4 parathyroid glands during a thyroid surgery, it can cause severe levels of hypocalcemia, low calcium, and that can be life-threatening in nature. It can cause issues with your muscles not working properly. It can cause issues with arrhythmias. And so finding all the parathyroids during this case and protecting them while you remove the thyroid gland is of paramount importance while we do this. And those are really the major, complications that we see. There are some other smaller ones that we occasionally see, but parathyroid surgery is the third and final complication we'll talk about. And when you ask how often does that happen, well, that happens on a very low level. Temporarily, people can have challenges with their parathyroids in up to 30% of cases. So people get discharged on calcium supplementation that helps them with their homeostasis. And then when their parathyroids wake back up after being disrupted and their blood supply gets a little bit, irritated because of us moving them during the case, the parathyroids will wake back up after 4 to 6 weeks, and the calcium levels will be normal again. If you ask about, well, how often does it permanently happen that people have issues with low calcium after thyroid surgery when they get a total thyroidectomy? The answer to that is less than 1% in experienced hands. So permanent challenges with bleeding, with parathyroid, with hypoparathyroidism, and with recurrent laryngeal nerve injury, all those things are exceedingly low for this surgery. But it's important to understand, what can happen when we do these things to folks. Now, you asked me when do people need lymph nodes removed during thyroid surgery? And what I would say is, for certain types of high-grade cancer, like medullary thyroid cancer, people need central compartment lymph nodes removed every time. Actually, our guidelines would state that people need a central compartment neck dissection for almost every medullary thyroid carcinoma that we see. For the more common types of well-differentiated thyroid cancer, like papillary cancer, it's more based on what the appearance of the central compartment looks like, either on the preoperative ultrasound. So if there are very suspicious lymph nodes in the preoperative ultrasound, we might remove them. If there are biopsy-proven lymph nodes in the central compartment during the preoperative workup, then we'll remove the lymph nodes. And honestly, sometimes it's just at surgeon discretion, right? If I'm in there and I see lymph nodes that look suspicious during the operation, I'll take out the lymph nodes based on their color or their appearance or how firm they appear when we're dealing with them and moving them and assessing them during the actual thyroid surgery.
That's a great answer, Jeff. I'd like to expand on one thing. So it's important that patients understand not all ultrasounds are created equal. And so what our policy is at Mayo Clinic is that if you have your thyroid ultrasound done with us, you always get the rest of the neck in regards to looking for any lymph nodes. So we call it lymph node mapping. And if we have a patient who came from the outside, many times we find they only had a thyroid ultrasound, but they did not have lymph node mapping. So we will recommend additional lymph node mapping being performed. And that sometimes also, then we find a questionable lymph node and we're not sure, we can do a preoperative bineedle aspiration biopsy of that lymph node, which then will help colleagues like Dr. Janis know that they do have lymph nodes that they're going to have to dissect and such. So I think it's important patients be informed that they really should have lymph node mapping of their neck before they have any type of thyroid surgery, because it can impact additional preoperative evaluation and the operation that's going to be performed. Again, if it's a under 1 centimeter papillary thyroid cancer, and we're going to assume it's not in the isthmus, which is kind of the horizontal part of the thyroid that connects the right and the left lobe, that's really close to the trachea. So we wouldn't want to follow that, because if it grew, it could get stuck up against the trachea and invade the trachea. Or if it's in the back part of the thyroid and more towards the middle part of the neck, it can be up against that recurrent laryngeal nerve. And so if it's no normal tissue all the way around the nodule, we wouldn't want to do active surveillance. But as I mentioned earlier, there is such a thing called active surveillance, and we can help patients determine, are they a candidate for active surveillance? And many of these nodules will stay stable for a long period of time, but it's important that they are under the active surveillance, which means regular ultrasound and seeing a team that knows what they're dealing with. What you wouldn't want to do is say, well, I don't want to worry about this, but I'm going to come back in 3 years or something like that, we wouldn't recommend that, because then the tumor could grow, it could potentially invade. There's always the possibility of metastases to local lymph nodes and such. Distant metastases can happen, albeit that's a little bit of a later phenomenon, typically with most papillary thyroid cancers, which are the most common type of thyroid cancer. So we are definitely open to active surveillance. And the other thing, and this is a whole discussion in and of itself, maybe for a later date, but there are non-surgical things we sometimes are open to considering in certain scenarios, such as thermal ablation. So if you have a microcarcinoma and you don't want to do active surveillance, but maybe you're not an optimal surgical candidate, then we can potentially offer thermal ablation, which uses radio frequency or laser type treatments to destroy the cancer. But that only can be really done in really small cancers. It wouldn't be appropriate for larger cancers. And again, the nodule would have to be in the right position and such. So there are more novel things that are not quite standardized that we are doing at the Mayo Clinic and being done some other places. But again, we're still learning about what the limits are in regards to doing that. But the big thing is to get follow-up. So even if you're doing active surveillance, follow-up, but if it's a bigger, more aggressive thyroid cancer, we're not going to want to delay. We're really going to think we're going to help the patient the most and give them the best outcomes by intervening. Well, I actually helped start our tumor board here at Mayo Clinic on Florida. And so our tumor board for thyroid nodules and thyroid cancer consists of endocrinologists that are really thyroid specialists or thyroidologists, of which we have several. And then, of course, we have our surgical colleagues like Dr. Janis in otolaryngology, or you could have somebody who is an endocrine surgeon, that's a general surgeon who's done additional training in endocrine surgeries. We have an interventional radiologist, again, who can help us with non-surgical treatments if it's appropriate. Medical oncologist, who, if there's systemic therapy or chemotherapy that's needed. Radiation oncologist, in case radioiodine would be pertinent, or sometimes external beam. We can sometimes have an actual pathologist with us. Usually our interventional radiologist does our radiology needs, but radiology. So Jeff, who have I forgotten? Have I forgotten anybody in the team?
No, I mean, the team is comprehensive, and you mentioned most of them. I think that so we've got interventional radiology, radiation oncology, medical oncology, endocrinology, and surgery. And those are that between that whole group, in addition to our radiologist who can review scans, has the ability to look at complex cases, take a perspective from every angle, entertain new and novel treatments to be able to deploy on these patients, and then in really tough cases, honestly, be able to collectively use everything that we've learned, everything that we've read as a multi-specialty group to be able to leverage a care plan for patients who may not be as straightforward. And for patients who are straightforward, there's lots of experience in the room to be able to determine the right path. So I feel like, I know just personally, since Vic helped start that thyroid tumor board years and years ago, I think it's matured into this entity that now we can literally be able to treat anything confidently when it comes to thyroid and parathyroid disease, and that's been a real gift for me as a surgeon coming here in 2020 or 2019 really. To be able to be part of that and to be able to contribute to that, and again, just continue to watch that grow and change over time. So I think it's a real asset here at Mayo Clinic, Florida, that isn't available everywhere, that we can use to our advantage to be able to take great care of patients who may have really, really challenging problems.
And to expand on that, Mayo Clinic is really known for collaborative care. And Jeff and I are in contact frequently during the week about patients. He knows as soon as I think a patient needs his or one of his colleagues' services, that I am contacting them and letting them know that a consult is coming their way, and that what particular concerns or discussions, and of course he has the notes referred to, but that's the nice thing about having all your providers under one roof where they work very close together, and there's a very robust communications, because then, sometimes we find out during discussions patient has certain concerns, and then we go back and forth after we've had an initial consultation, said, oh, didn't realize the patient had that concern, and well, we have this option or that option. And there are times, and we can't promise this, but where I have a patient in my office and they've come from a distance, and I contact Dr. Janis, one of his colleagues, and they will say, you know what, I can get that patient in this afternoon or tomorrow morning, and we can see them and go over and then come up with a treatment plan. And or sometimes I've seen them by video. They live several hours away, and then I know they need thyroid surgery. They see Dr. Janis by a video appointment, and then when they come visit the campus, they basically have their preoperative evaluation. They then have their surgery, and they can have it in a very condensed itinerary, and they get to see all the people that they need. They get excellent care, and then they can go home to heal and know that they've done everything that they need to do.
I think it helps that Vic writes them.
Well,
I think
so
that's definitely as up to date as you can get. He knows about it before everybody.
yeah, so I've been very involved and been very privileged to serve in the American Thyroid Association for many years. Have been in the leadership both as the secretary, chief operating officer, and later as the president of the American Thyroid Association. And as Jeff alludes to, I am actively on the guideline committee for thyroid nodules. I'm very familiar with the thyroid cancer guidelines that will be coming out, because they're both being updated, and get to see early editions of that. I'm very active in presentations and attending presentations at the American Thyroid Association, and also involved in something called the International Thyroid Oncology Group. On their board of directors, and that is a select group of about 150 members who are thyroid experts throughout the world, and we meet every year and go over. I have an academic meeting where we go over all the new and latest and greatest diagnostic and treatment options for patients with thyroid cancer. And a lot of times that addresses people with more advanced thyroid cancer. And so I think that's important, is we know the literature, we know what's the latest and greatest. And then again, also participate as a Mayo Clinic. We have membership in the National Comprehensive Cancer Network, NCCN, which also comes out with recommendations for guidelines, and I've been the rep for that. So, and this is something where we are very academically involved. We're publishing and doing research projects. And so, yes, I think that's important that patients know that our team stays on the very front line of things.